Next topic will be approach to the two common syndromes that we see predominantly with the more with cancer patients, tumor lysis syndrome and neutropenic sepsis. So at the outset, I'd like to thank Dr. Rajesh and the entire MSW team for having me here, and congratulations for this successful program. And I also have a complaint on this organizer and the previous organizer. Both times I was made to talk after tapas, and it's a very, very difficult bar that he sets to catch up with. Right. So I'll be talking about this important syndrome, which is probably a fairly common problem that we see, particularly for those ICUs who take care of a lot of onco-critical care services. So historically, it was well known that this particular entity, what we call as tumor lysis syndrome, again, it's a syndrome. It will be a multi-system organ involvement or a presentation. Was predominantly from hematological malignancies, particularly Burkitt's and ALL. But over time, it has actually widened, or we are actually seeing much more newer malignancies that are coming in this bracket where they actually end up having tumor lysis. Reasons could be manifold. Of course, there are evolution of tumors which have happened genetically, and more importantly, I think we have better chemotherapeutic agents and even targeted agents. In spite of having targeted agents, you are likely to have tumor lysis based on certain factors. Now, how do you define tumor lysis syndrome? Essentially, TLS is a situation where, very simplistically putting, you have a whole lot of mass of cellular breakdown which happens, and these intracellular substances are actually released into the system or into the systemic circulation, and that ends up causing a whole lot of problems, which will overwhelm the normal excretory mechanisms of the body, resulting in a multi-system organ failure and electrolyte abnormalities or metabolic abnormalities. That is in very brief or very sort of common man terms of how you would explain tumor lysis syndrome is all about. So what are the predominant problems that happen? Most often it is dependent on what are the intracellular substances that get released, and these include uric acid, phosphate, calcium, potassium, and a whole lot of other things as well perhaps. But these are the ones which are clinically significant, which result in a whole lot of problems that we see. And the manifestations of these electrolyte metabolic substances are what we actually end up dealing with, which includes AKI, seizures, tetany, probably because of hypocalcemia, arrhythmias, and muscle weakness. Now, having said that, this is a sort of summarizing slide of the pathophysiology of tumor lysis. So we spoke of a few things. There are quite a few other substances also which get produced, as you can see here, which may not be of much clinical significance, but yes, it has a role to play. And of course, based on this, we also have interventional strategies that are put into place. So grossly, the tumors which cause TLS, as I already mentioned, are those which have a high proliferation rate, a large tumor burden, and also there is an entity called spontaneous tumor lysis syndrome, which which are more often seen these days, where it does happen because of even in spite of not having treated or not having undergone chemotherapy, more to do with the mass and the rapidity at which the proliferation of the cells actually take place. Now, the definition also has evolved over time. The earlier definition was a combination of a lab and clinical definition. As you can see, you can take a snapshot of this. I will not go into each one of the component of the definition. The slides will be shared with you, more so because of lack of time. But what I want you to understand is that the more recent definition is the one which was put out in 2011, which is what I want you to concentrate on, because that is where you actually have an elevation of uric acid, potassium, phosphorus, and of course hypocalcemia, where all these put together, and if there is at least 2 of these abnormalities, then you would suspect tumor lysis. If this happens within 3 days or within 7 days after completion of the therapy. So the definition is important. The timeline and at least 2 of the entities going wrong put the category of, or would come to the diagnosis of what we consider as tumor lysis syndrome. Now, what are the risk factors? Anytime when we talk about risk factors, we always talk about, as you know, the genetic factors, the host factors, the patient factors, all these come into the play. So here again, similar to that, there are no host factors, there are no sort of parasite or infective factors, but we talk about the type of tumor. So I think I've dwelled upon it for quite a bit. So the type of tumor does have an important role to play, and I told you traditionally it is the lymphoblastic tumors, the hematopoietic cells, of course, which are those tissues which have high rate of growth, which have high rate of proliferation, are the ones which actually produce these kind of problems. In addition to that, patient factors also play a role. If there is a previous history of AKI, nephropathy, oliguria, inadequate hydration, patient has poor premorbid status, all these can contribute. And of course, the type of therapy that comes into play also plays a role in actually putting or considering what are called as the risk factors. Now, how do you manage? Whenever we talk about management, there are two important things. One is to know whether you can prevent the problem. Second is to identify whether the patient needs to be admitted. You can do it as an outpatient. If you're going to admit, are you going to admit in an inpatient ward, or are you going to get the patient admitted in the intensive care unit? And as Dr. Tapas always kept saying, that is how you would also write it in the exam. When I talk about management, you would probably put a few lines on preventive. You would probably say what are the risk factors, prevention, and then of course you would say that I would assess the risk and I would assess the severity, and then I would categorize it into the different kind of treatment strategies that we are going to use. So the cornerstone of prevention is of course hydration, because we know that this is the pigment-induced problem or a protein-induced problem, like how we have rhabdomyolysis. In the same way, tumor lysis has a lot of heavy molecules and electrolyte abnormalities, which directly have an effect on AKI, on the renal, on causing nephrotoxicity. So hydration is a very important preventive strategy or a protective strategy for the kidney. Now, what fluid we use, of course, is going to be potassium-free. It could be NS, it could be half NS, but electrolytes are the way to go, and not certainly glucose or a water-based solution. The other aspect of it is whether we use diuretics or not. Now, this is a very sort of gray zone, I would say. For a long time, we believe diuretics are bad, but today we know that diuretic challenges are used in various situations in the ICU for AKI. So I think that will be based on the assessment that you would be actually putting other things into the things, where you assess the volume status, maybe use the ultrasound, maybe use any other technique that you have to assess the volume status. If you are sure that you have filled the patient adequately, then you go for a challenge or a diuretic challenge. The second important problem is management of hyperkalemia. All of you are experts in the ICU. I will not go into the details of it, but it is important to understand that hyperkalemia is a problem, and before it gets out of hand, you have to intervene. Whatever it is, you can use salbutamol nebulization, dextrosinsulin, soda bicarb, plus minus in this situation, because bicarbonate itself is known to worsen the precipitation of these pigments in the kidney. So people are now moved away from using soda bicarb in this particular setting, and of course dialysis as a last resort. So these are some of the things that we use for management of hyperkalemia. Hypocalcemia is a problem, but generally asymptomatic in patients with tumor lysis. If at all you find that there is significant hypocalcemia, then of course the correction would be done. But otherwise, unless there is symptomatic or clinically significant hypocalcemia, we would not be correcting hypocalcemia in this particular syndrome. Hyperphosphatemia, again a problem, and most importantly, you use phosphate binders, calcium carbonate, etc., and dialysis as a last resort. Now, for the management of hyperuricemia, I already told you hydration is the way to go. Now, there are two important drugs that have been used. Allopurinol is a good old drug which we have been using. Now, where it acts, how it acts, I'll show you in the next slide. And the newer drug called Raspurigase, which has been used initially in the pediatric population, but there is significant data now for its use in patients to prevent in patients whom there is high risk of developing tumor lysis, or also for the management of TLS. So Raspurigase is nothing but a recombinant uricolitic agent, where it acts at the level of, where it actually blocks the enzyme urate oxidase, which is the last step of the whole sequence of reactions. And of course, allopurinol is a xanthine oxidase inhibitor. Now, a lot of clinicians now use both in combination, but if you look at data, it says that one of the two is useful, but combination, there is no data to say that the combination is better. But in clinical practice, people have used both, where they use Raspurigase in the dose of the first 5 days, or use the dose of 0.2 milligram per kg per square meter area for about 5 days. And on day 1, day 3, day 5, they use allopurinol, and sometimes continue allopurinol after that. So, in summary, it is important to identify the problem. You identify the risk of the patient developing the problem. And if there is a low risk, then of course you just keep monitoring. But if the patient is likely to be of high risk or has already developed the syndrome, then you address the situation as per the necessity, which is largely going to be supportive. So this is the sort of overall flow chart of what I spoke. Again, a bit of a crowded slide, sorry for it. You can download it from any other thing, but you can take a snapshot if you think it is necessary. Okay. Right, are we still awake? Can we go to the second part of it? In fact, when Dr. Manjunath sent me the two topics, I was wondering whether I should have two views in one patient, but I found it is too complicated, so I thought I will break it up and use it as a two separate topics. So the second part of the topic is approach to neutropenic sepsis. Now, it's not a new entity. Neutropenic sepsis, I think ever since we all have gone through medicine, gone through pathology, we know what neutropenia is, what sepsis is, in fact what a neutropenic fever is, because I think we have moved from neutropenic sepsis more towards neutropenic fever, because if we can block the problem at the level of neutropenic fever, so most of the newer articles are more talking about neutropenic fever rather than neutropenic sepsis itself. In fact, most probably the recent articles which are talking about neutropenic sepsis are at least about 4 or 5 years old. Of course, you can argue that COVID came in the middle, but that's how it is. But a lot of newer articles talk about neutropenic fever, because if you can find the problem at the level of the fever and manage it accordingly, then it will go a long way in actually improving mortality. So ever since the first paper in 1966, which was published by Body and colleagues, this has come a long way, and we have learned a lot of new things, but it is still a problem in the intensive care unit. If you look at patients who go through different kinds of immunosuppressive therapies for cancer, I mean, I'm largely dealing with malignancy part. Of course, there are congenital neutropenic problems. I will not get into that, because in the critical care population in the ICU, we are largely dealing with either post-drug induced or post-chemo or post-cancer therapy. So neutropenia in the setting of cancer, of course, adds to the mortality. Attributable mortality can be as high as about 20 to 40% in patients who develop neutropenic sepsis during therapy or during their journey of having gone treatment for malignancy itself. Now, what is the scale of the problem? It is pretty huge. If you look at data from the United States, of course, as always, we don't have much data from our country, but if you look at data from the United States, you would actually say that the cost of therapy increased by about $6,000 for 3 days in the ICU. And of course, subsequently, there are other non-tangible costs which we can't measure. The productivity, the beds being occupied, a whole lot of other things that come into the play. And it also depends on what is the kind of infection we are dealing with. And today we talk about much more complex infections. We talk about infections which we didn't see 10 years ago. It's not the Pseudomonas, not the Klebsiella, but we talk about Xenotrophomonas, we talk about Rhizobacterium, and an increasing load of fungal infection. As you know, today we deal with Candida auris in many of our patients, which is a very, very difficult fungus to treat. Now, the reason for the mortality and morbidity, as I told you, is not only the primary problem, but also there is immunosuppression, yes, but it is also to do with the fact that we are actually dealing with a lot of these commensals which are inherently resistant to most of our antibiotics, and when they become infective, or these so-called commensals break through the barrier and become infective, then it's really a tough challenge to treat these patients. Now, over the last few years, what has changed, what is new in the management of neutropenic sepsis is something that we need to understand. Historically, we all know about the gram-positives, and of late a little more about gram-negatives. But more importantly, we are now dealing with not ESBLs, but if the patient has spent a certain amount of time in the ICU or has been visiting the hospital frequently, what we call as category 2 or category 3 patients, we actually find that they are colonized with our carbapenemase resistant bacteria or something more sinister, and we end up having difficulty in treating these patients. So your first choice of drugs now in somebody who comes with sepsis after immunosuppression is not going to be only carbapenem. We actually look at something much bigger, that or a combination of chemotherapy or combination therapy. So that is the problem. The other problem is increasing incidence of Pseudomonas. I mean, I know that many of our ICUs still don't have Pseudomonas as a major problem. It's probably 10 to 15% of our total isolates of gram-negative that we deal with, but it is an increasing problem. And I promise you that if Pseudomonas becomes your Klebsiella, then I think we are going to be really having a lot of problem on our hands. And of course, the way the guidelines have formed also is a bit of a gray zone, because first of all, guidelines for sepsis has been still evolving. We don't have a proper definition for sepsis even today. If you look at the 2021 guidelines, they have dumped the 2016 guidelines definition, and they said you can have your own way of diagnosing sepsis. It could be SIRS, it could be NEWS, it could be whatever. But it is important to have your own criteria, which is well made for your local center. So I don't have a proper diagnosis for a definition for sepsis, other than saying in a very broad way that it is a dysregulated host response. And then I add neutropenia on that. Of course, I'm going to have challenges in making the diagnosis of neutropenic sepsis in the ICU. So that is very, very important, because if you don't make the diagnosis or you overdo the diagnosis, then you have collateral problems of using antibiotics unnecessarily or abusing the antibiotics. So firstly, the definition of what is febrile neutropenia. It's nothing but a one-time oral temperature of greater than 38.3 degree or a sustained temperature of 38 degree plus for more than 1 hour in a patient who has absolute neutrophil count of less than 500 for a period of within a period of 48 hours. So a person who has neutropenia, which is less than 500 count within 48 hours and has these two types of fever pattern, 38.3 one spike or more than 38 degrees centigrade for an hour. Now this is very important because otherwise you see that most of your nurses 99 degrees they will say it's a fever. So it's very important to define fever, and particularly in the context of neutropenia the definition of fever is very important because even that subtle fever of 38 which can be there for an hour could mean a lot of other things. Now this you club with the diagnosis of, with your definition of sepsis, that becomes neutropenic sepsis, and of course then you have septic shock and other things which I will leave it for the moment. Now what are the fallacies of the diagnosing sepsis or sepsis in a patient who is neutropenic? First and foremost, the primary disease itself may mimic sepsis. You say somebody has AML, somebody has CML, somebody has a malignancy that can produce a surge response, and you're actually juggling to know that this surge response is because of the primary problem or is this surge response because of a underlying or a new onset of a sepsis. So the overt signs of sepsis may be often obscured or masqueraded by something else. And in many situations, as I already told you, non-infective causes can be there. It could be like a graft versus host disease, or it could be a reaction to a immunotherapy drug which has been given. Very commonly, if somebody gets an immunotherapy drug, they come with the ARDS or they come with a surge response. We see it quite often. Role of biomarkers to help, yes, there is some data, but not enough to say that we can use that as an end all and be all to treat, or even to say when I will stop treating these patients with antibiotics, and the rapidity with which we can diagnose the problem. Now I can't wait for cultures to come 48 to 72 hours. There is an evolving science on the molecular genetics or molecular multiplex PCR technologies, and there are a lot of companies today in the market, Indian, international, which have come out with a whole lot of panels that they talk about. But we need to understand that there are pros and cons. You probably will pick up the problem early, but then the sensitivity is too much and the specificity is not that great. And especially if it is a sample which is not a sterile sample like a ball or a urine, then you don't know what you are treating with. And sometimes even when blood is sent, you actually find 2-3 things coming positive. Now whether you want to treat that or not is anybody's guess, and that's why interpretation at the bedside becomes very, very difficult. Now, along with the neutropenia, there are also certain risk factors which can contribute to these patients coming to you or developing sepsis. Now, this is also going to be a part of your approach to the algorithm, because it is not only having neutropenia, but why the neutropenia is, how long the neutropenia has been there. If it is for more than 7 days, as you can see in the first box, then it includes that the risk of developing a neutropenic sepsis is much higher, or the mortality and the morbidity is much, much higher. So the depth of neutropenia, the duration of neutropenia, what is the reason for the neutropenia? These are 3 important things that we talk about, and among that, acute leukemias are known to be contributing to risk or mortality much more than what you talk in other forms of neutropenia. Of course, prolonged hospitalization, recent surgery, advanced form of the disease, delay of ICU admission, long stay in the hospital, previous procedures, exposure to antibiotics, exposure to chemotherapy agents, presence of an indwelling catheter. These are all sort of general risk factors that we talk for ICU illnesses, does hold good, and they also add to the mortality and morbidity or the risk of developing neutropenic sepsis. Now, what about the treatment guidelines, resuscitation guidelines? Largely goes by the 2021 guideline. The 2018 German European guideline, which came for neutropenic sepsis, kind of follows the same route. They have, of course, used the 2016 guideline because the 21 guidelines are not available. But most authors say that the practice of treating sepsis, septic shock, would be like how you do for a patient with otherwise sepsis. So that's why the 21 SSC guideline will probably be your template on which you would be treating these patients. But more importantly, it's also important to categorize the risk of these patients. As a 2 minutes, I'll be done. This is a 5-minute bell or the last bell? Last bell. 6-minute bell. Okay. Right. So categorization of these patients using the mask criteria. Again, you can take a snap. It's available on Google. And if the score of this is less than 21, then that would mean that the risk of developing neutropenia is much higher. So this will be the broad algorithm on which you will be going. Somebody has neutropenia, are they developing sepsis or not? What is going to be the risk factor? These are the things on which you are going to look at managing your patients. Now, regarding the diagnostics, as I told you, there is increasing role of PCR technologies, particularly in the immunosuppressed. There is data coming out, but I think we still have to take it with a pinch of salt. Diagnosing fungal infections with the use of various kinds of interventional procedures, ultrasound procedures, radio diagnosis based procedures, especially CT of the lung, for example, may have a characteristic pattern. You could use biomarkers like galactomannan or 1,3-beta-glucan, which also have a role to play, and a lot of newer techniques are on the way. Now, there are a number of other ways in which you decide your empiric antibiotic choice. Now, this is just a snapshot from one of the review articles, but I am not going to recommend this. But what is more important is it a neutropenia which you can manage at home? Is it a neutropenia which will need admission to the ward? Is it a neutropenia which has shocks? I think these are the 2 or 3 important criteria that we're going to talk about. And for somebody who comes to you to the ICU, this is a very important part of the treatment algorithm. So you decide based on the local data that you have, your local flora, fauna, and your sensitivity pattern, what is the biggest problem that you have, and then most importantly, as I said, risk stratify the patient. So everybody will not go on to meropenem, fosfomycin, Klebsiella treatment. No, it will depend on all these things. So even somebody who is in the ward, we use BLBLI as our first choice. So if it is OPD treatment, there will be a set of drugs that you will have to have in your backyard. If it is going to be IP admission in the ward, there's going to be certain medication. And if it's somebody coming with shock, of course, you don't have a choice. And that is why I've just highlighted this particular one here. The approach may be more likely de-escalation, because in the previous 2 we said escalation matrix for antibiotics is likely to be your approach strategy. Okay, and other big question is, are you going to add antifungals? If so, when, how, what fungals you are going to cover? These are some of the things that we are going to decide. So in short, this is again one of the algorithms which is there, but you could follow anything which you are comfortable with. But most importantly, write this algorithm if you are given a question on approach to neutropenic sepsis in the exam. Have one algorithm in your mind, and it's very important to define neutropenia. Very important to define the duration, risk factors, what is causing neutropenia, and all the other risk factors that I spoke to, and of course then following that, how sick is the patient, and the rest of the thing will follow suit. Thank you.